beautiful in Central Oregon. So, if I don't know you and I haven't met you, please come talk to me at the break or at the end, because I do want to know you. We have an incredible lineup, but right now I want to introduce my executive director with the foundation. She is with Epilepsy Foundation, Oregon, Washington, and Alaska, Sharon Cup.
Good morning. You are beautiful. I'm looking at all of you. Look around. Look at us. We're here because we care about epilepsy. We care about each other that live with epilepsy. And we are going to make a difference. And I'm here wearing my End Epilepsy t-shirt this morning, which if I was a tattoo person, I might have it tattooed. But I am wearing it because I believe that there is a future that our epilepsy will be cured, will be different, and it's because of all of you that that difference will happen. So I welcome you here today for our first annual, could this be annual, Epilepsy Awareness Conference here in Central Oregon. And we know that you all aren't here from Bend. You're from all over Central Oregon, so we welcome you. Raylyn mentioned that we are the Epilepsy Foundation Oregon. Well, a month and a half ago, we were the Epilepsy Foundation Northwest. There was a big change that happened on October 1st, an exciting one for all of us, that we are now the national organization. We are stronger because we are together with national. They are bringing resources to us. They are helping us be able to have our impact be even greater here in Oregon, as well as Washington and Alaska. So I hope you'll get a chance to pick up a magnet that has been refrigerator tested, so it can go on your refrigerator.
They stick to your car.
That
all the way over from Portland.
It's on. Love it. Love that. So please, it's got our new website on it. The website is about a week and a half old. If you see things on it that you're like, oh, I'd like it to be different, or this isn't right, let us know. We're into improvements. You all know that anything's new can be improved. But we're very excited to have the Epilepsy Foundation Oregon up and running. In another couple months, we will actually be even adding another staff person. So that's about us increasing our impact. We are here to serve you and to make our community stronger. And with that, we are very delighted to be here at the incredible St. Charles Health System Center here in Bend, and we could not have done this conference without St. Charles, so we're very appreciative, as well as Dan Chris. Where are you, Dan? Dan, thank you. You have been the man that has opened many a door. Thank you so very, very, very much, as well as our volunteers that greeted you as you came in the door, that have helped with getting all this set up. We are nothing without our volunteers, so we thank and appreciate each and every one of you. Here in Oregon, we have a board of directors. We have 12 advisory board members, and today we are fortunate to have 6 of those members with us. We have our advisory board chair, Bob Schomer. Bob, how about a little to your people? Bob, thank you. Other members of our board, I see Dodie, if you will stand. I see Jody, if you will stand. I see Leslie, if you will stand. And Scott.
Yeah.
And later we'll have Dr. Colin Roberts, who's also on our board, be with us today. So with that, I am going to turn it over to Scott. But again, I want to remind you, grab your magnets so you can find our new website. I'll be with you all day. Raylyn mentioned that I came from up north. I live in Seattle, so the 331 miles to get here, not a big deal. I'll do it any day. You've got sunshine and you're beautiful people. So thank you. Scott?
I have the privilege of introducing our speakers today. So our first speaker is Dr. Bell. right here from Ben. He's a board-certified neurologist at Ben Neurological Associates. He graduated from the University of Oregon. Go Ducks. He went to medical school at Oregon Health and Sciences University and went to do his internship, residency, and fellowship at the Mayo Clinic in Rochester, Minnesota, which is where he served as an assistant professor. He has participated in a variety of research in the past and is a member of the American Academy of Neurology. Dr. Bell has been practicing in Ben since 2007 and joined Ben Neurological Associates in 2010. In his personal life, Dr. Bell enjoys spending time with his wife and children. You can find him kayaking or in his drift boat fly fishing. He enjoys all of Central Oregon's backcountry activities, but in his heart, he's a family man, and we appreciate him being here. Please join me in welcoming Dr. Bell.
Can you all hear me okay? Thanks, Scott. What a privilege it is to talk to this group. I'm just curious who I'm talking to. So how many of you are in the healthcare field? Quite a bunch. How many of you are physicians? Okay, great. So my talk today is going to be pretty fundamental. I'm going to walk you through seizure types. Then we'll up our level of sophistication to talk about epilepsy types. And then we'll go up one more notch to talk about epilepsy syndromes. This is a huge topic for 45, 43 minutes, so buckle your seatbelts. This is my youngest daughter flying over the Oregon coast here, and I think that's about what you're going to feel like today. We're going to fly through a lot of information. So if it's okay with you, go ahead and leave questions for the end, and just in the interest of time. So the first fundamental question is, what is a seizure? We all think we know intuitively from Hollywood or from what we've seen, but sometimes it's a little surprising what seizures can look like. So I want you all to guess, and I'll ask for a show of hands, who thinks this man's event is a seizure? Pay careful attention to his right hand at the end of the event, which is actually a very important clinical feature as his wife tackles him. So you can see we're recording his brain waves, so we actually know if it's a seizure or not. So kind of a strange spell. How many of you think that was a seizure? Okay, a few people. So that was a seizure. That was an epileptic focal seizure from the frontal lobe, which is part of the brain that involves emotional control, limbic areas, motor control. So focal seizures can affect any part of the brain and can cause some very unusual symptoms depending on what part of the brain is activated. And actually that right hand thing he did at the end was what we call an ipsilateral automatism, which indicates that the right side of the brain is the side of the brain that's seized. So that was a right frontal lobe seizure. To make you all feel better, when you show this to a group of neurologists, they're about 50-50 whether it's a seizure or not, so you did okay. But I love this video because it illustrates what a seizure is. Number one, it's paroxysmal. So what's paroxysmal? Think of, somebody paroxysmal laughter. It comes out of nowhere, out of the blue. Number two, it is transient, meaning it has a beginning, it has an end, it's a temporary spell. So it doesn't wax and wane, it doesn't come and go, it's an event. And then thirdly, it's caused by firing nerves. It's a hypersynchronized discharge of nerves, which you can think of as like a short circuit, maybe a few 100 million or a few billion nerves in this case with the focal seizure. So it's kind of like a short circuit of the brain. Now, the term epilepsy is not synonymous with seizures. Epilepsy simply means, number one, recurrent seizures, and number two, unprovoked seizures. So if you have a unprovoked seizure, that is not epilepsy. If you have provoked seizures, like my daughter over here nodding her head who had a febrile seizure, recurrent febrile seizures is not epilepsy. Alcohol withdrawal seizures is not epilepsy. So unprovoked, out of the blue seizures that happen more than once is epilepsy. So you can imagine that that term encompasses quite a wide variety of conditions. So the term epilepsy is very generic and really encompasses hundreds or thousands of situations and conditions. So let's talk about seizure types to lay the groundwork for understanding epilepsy. So in general, I teach my medical students, you need to understand how seizures start, because then you can choose the appropriate medication. So they can either start in part of the brain, which is synonymous with focal, or it can start in the whole brain, which we call generalized. And you can fine-tune that. We talk about, in the old days when I trained, we talked about simple partial, meaning no loss of awareness, or complex partial, where you do lose awareness, you blink out. And then those focal seizures can spread from part of the brain to the whole brain, causing what we call a secondarily generalized tonic-clonic seizure or convulsion. And there's different types. Any part of the brain can seize. So you can have, quite commonly, memory areas causing blankouts or memories, deja vu, things like that. You can have so-called autonomic symptoms, like rising feelings in the belly, or your hair can stand on end, or a smell or taste kind of sensation. You can have sensory symptoms like numbness, or I had one unfortunate patient whose seizures felt like her leg was being dipped in boiling oil because the pain part of the brain was the location. So depending on, and then of course you can have motor. You can have a partial motor seizure, like a so-called Jacksonian march that starts in the hand and spreads up the arm into the face. And then if it spreads to the whole brain, it causes what we call a secondarily generalized tonic-clonic seizure. Now, seizures that start everywhere at once, there's two most common types. There's the ones we see on TV, which we call generalized tonic-clonic. Tonic means stiff, clonic means shaking. So it starts with stiffness and then evolves to shaking, and you're going to see that today. Or the other common type is absence seizures, which are brief little blankouts, different than complex partial, much briefer, much blander, maybe 2 to 10 second space outs typically. There's a lot of other types of generalized seizures. There's myoclonus, which is like a lightning-like jerk. Tonic, where you stiffen for 8 to 10 seconds. Clonic, where you just shake from the start. Atonic, where you just go limp. These are the situations that can result in injuries. And then there's this really terrible type of seizures that affects babies, called infantile spasms. This was initially described in a beautiful article by Dr. West to The Lancet, where he talked about a 10-month-old infant who started having these 1 to 2 second stiffening spells. Sometimes the arms go up, sometimes there's trunk flexion, trunk extension. They tend to cluster during times of drowsiness, like nap time or on awakening. And he described a characteristic very abnormal EEG and progressive developmental decline in this child, who tragically was his own child. So we now know this as West syndrome, one of the epilepsy syndromes that often leads to some of the toughest epilepsy we see. So for those of you who knew all of that, let me tell you that the International League Against Epilepsy is trying to make my life confusing by changing everything last year. So we're no longer supposed to use the term partial. The new term is focal, meaning part of the brain, focal seizure. We're no longer supposed to talk about simple partial or complex partial, but instead aware or impaired awareness seizures. Kind of makes it easier to talk about, I think. And instead of secondarily generalized, we simply say focal to bilateral tonic-clonic. So my head's spinning, so if yours is spinning, don't worry, so is mine. They also added a category of unknown, because sometimes we don't know. And so here's the new simplified classification. You can have focal aware, focal impaired aware, you can have motor or non-motor, and then if it spreads to the whole brain causing a generalized tonic-clonic, or in the old-fashioned term grand mal, we call it focal to bilateral tonic-clonic. And then there are the generalized seizures like absences and tonic-clonic. Now, if you want to kick it up a notch, we can talk about all kinds of different specific motor and non-motor types of seizures. For example, the gentleman you just saw had what we would call a hyperkinetic seizure. That might include bicycling. You can have very commonly behavioral arrest seizures. That's one of the most common partial seizures we see, where people stare blankly, like the lights on down home. Maybe they smack their lips or pick, which we call automatisms. Don't mistake that for absence seizures. You know, I often have ER docs call me with consults and they say, well, this 30-year-old started having absences. Well, 30-year-olds don't start having absences, and absences are brief, bland space outs with generalized discharges on EEG, whereas impaired awareness focal seizures tend to be much longer. They tend to have lip smacking or picking or other signs, so they're not the same thing. One is focal, one is generalized. So let's put this to practice with some examples. Now this first example, you're going to see a focal seizure become generalized. And I have to warn you that it's hard to watch. For those of you not used to seeing this, it can be emotionally difficult. So if any of you feel like this is too much, please feel free to leave the room. But I think it's important. It's important for us to understand what seizures are and what they look like. So this young woman has spells where she blanks out. Her family describes seeing her stare blankly like the lights on no one home, smacking her lips. And nobody's ever seen her have a tonic-clonic seizure, but they described once that they found her with a tongue bite, unresponsive drooling, presumably the aftermath of a seizure, the so-called post-ictal state. She also describes preserved awareness events, or auras, where she has a rising feeling in her abdomen and an out-of-body experience. So her partial seizure just started. You see some picking automatisms, as we call it. You can see the blank stare that is so striking. People say lights on, no one home. Again, much longer than an absence, right? So she's unresponsive, and now the seizure is going to spread to the whole brain. So that's the so-called epileptic cry, and now she's in the stiff tonic phase. And then you'll see that the clonic shaking starts. It's long, isn't it?
That's Richardson.
I'm sorry, I intended to turn the volume down lower than that. That is frightening to hear. What I want you to also notice is after the seizure, how she's drooling and her airway is floppy. So the seizure just ended. And this is what we call a post-ictal state, after the seizure. So her brain's exhausted, she's drooling, and you're going to see her aspirate on that drool.
Hello. Yes, this is right.
So my advice, if you ever see somebody having one of these, is afterwards roll them on their side so they don't choke on their drool. You're going to see why here. So she was out of it, so-called stuporous, because her brain was exhausted after burning all the energy supplies. And you saw her choke on her secretions. That's why they often can get pneumonia after seizing. So when patients ask me what to do during a seizure, I say, number one, time it, because a minute feels like an eternity. Number two, if it lasts longer than a few minutes, call 911. And number three, after it's over, roll her on her side so she doesn't choke. Don't put spoons in the mouth, you'll just break teeth. You know, if she's going to bite her tongue, she'll bite her tongue, that's unavoidable. So, how would we categorize this? Well, it began focal, so I would say this was a focal impaired awareness, non-motor behavioral arrest seizure, and then it became focal to bilateral tonic-clonic. You all doing okay? I could see that was emotionally tough for many of you. Here's another example. This young man had focal epilepsy, ultimately had epilepsy surgery, and became seizure-free. He was having 8 to 10 of these a night, and they were disrupting his sleep. He was exhausted, falling asleep in class. He'd broken bones from seizures. He has so-called bicycling movements of the legs.
Okay, all right. How you doing, Frank? Frank, how are you?
You can see he's a little confused afterwards, the post-ictal state. So this young man had a normal MRI, but ultimately they found where the seizures were coming from and resected that part of the brain. He became seizure-free, and he went on to live a normal life. So his, again, would be focal. I'm not sure if it was aware or impaired awareness, but we would call that hyperkinetic. So that gives you a sense of how seizures aren't always what we think of. Now I teach my medical students that distinction between focal and generalized is critical, because that's how you select an appropriate medication. So in the 70s it was easy. We only had phenytoin or Dilantin, we had phenobarbital, and then we had ethosuximide, which was a drug only used for absence epilepsy, not effective for other types. Then in the 70s, a few more drugs came out, carbamazepine or Tegretol, which is the sodium channel blocker like Dilantin or phenytoin, and then valproic acid, valproate or Depakote, which has become our gold standard for generalized epilepsies. Then since I was in high school, since the early 90s, we've just had a burgeoning of options. Many different medications, all kinds of new therapies for epilepsy since then. Now for focal epilepsy, basically anything works except ethosuximide, which only works for absences. So really, we pick medications based off side effect profiles. Whereas when you see patients with generalized onset seizures, it's a more limited list. We tend to reach for Depakote, valproic acid, or lamotrigine, Lamictal, or a few others like levetiracetam, Keppra, topiramate or Topamax, zonisamide or Zonegran. So it's a more limited list for the generalized onset epilepsies. So that's seizure type. Let's kick it up a notch to epilepsy syndromes. So here's a very common epilepsy syndrome. This was a college freshman. He had been out drinking the night before, had several alcoholic drinks, stayed up till 2 a.m., and then walking to class the next morning, had a generalized tonic-clonic seizure for the first time. And so in hindsight, you ask him about morning tremor, and he says, yeah, in the morning time, I tend to spill my orange juice, drop my toothbrush. I have this funny jerking when I wake up from sleep. And here's what that looks like.
How long did you stop for?
So you can see it almost looks like a shock. It's so fast.
Okay. We're going to cage you in, okay? Proceed. We do it on everybody, whether they're 3 months or leave. Try not to stop or do anything for it. We need to do this for you. You know, well, we want to, that's it, because we're recording it. And sometimes if you're trying to stop.
So that would be an example of a generalized onset, since the whole body was shaking, motor, and specifically myoclonus. Myoclonus is a shock-like jerk, much faster than clonus, which is more of a rhythmic shaking. So in this kid, instead of just describing his seizure types, you can describe a syndrome diagnosis. So he has juvenile myoclonic epilepsy. Juvenile means teenage onset. Myoclonic jerks, this condition is characterized by those myoclonic jerks on awakening, and then generalized tonic-clonic seizures triggered specifically by alcohol, often the night before, or sleep deprivation or flashing lights. And it has a very characteristic EEG with very fast generalized discharge, 4 per second spike and wave generalized discharges. And what's fun about making this syndromic diagnosis is that I can be much more specific in telling him what the future holds. I can tell him that usually low doses of an appropriate medication for a generalized epilepsy will control this, usually. And that this condition usually persists until adulthood. And I can tell him to be very careful about the triggers. For instance, I had a college professor who every decade he would fly to Italy and have a bottle of wine and be sleep deprived and have a seizure. And when he was in his 50s, we figured out this is what he had. So it's very sensitive to those triggers. So that brings us to this topic of epilepsy syndromes. So there are, this is an incomplete list of all the epilepsy syndromes, and we're going to touch on every one. No, just but each of them have their own unique clinical, EEG, and natural history story and MRI findings. And so you can be much more sophisticated in how you advise people if you know their specific syndrome. Let me recommend this excellent website, epilepsydiagnosis.org, which runs you through seizure types, but also epilepsy syndromes. So for example, here on the website, I looked under epilepsy syndromes, childhood, Lennox-Gastaut syndrome. This is one of the most common epilepsies. It's often what the children with infantile spasms grow up to have. This is characterized by very tough epilepsy with multiple seizure types: tonic, clonic, tonic-clonic, myoclonic, absence, drop seizures. And it's associated often with developmental delays. And so if you hop on the website here, you can even see videos of the different seizure types. It's an excellent tool. So we've worked our way from seizure types, which can be focal, generalized, or unknown, to epilepsy types, which can also be focal, generalized, unknown, or sometimes both, like a lot of these Lennox-Gastaut situations. They may have a focal lesion, they may have focal seizures and generalized seizures. But now we're going to move on to talking about more of these epilepsy syndromes. And in the backdrop of all this is the cause, the etiology. So we're increasingly trying to be specific about the cause. If it's a focal lesion of some sort, like a malformation of cortical development, you might see in a child with epilepsy, presenting with epilepsy. a genetic cause, like a specific gene mutation, an infectious or autoimmune cause, like an antibody that inflames the brain. So epilepsy syndrome doesn't always tell you the cause. So let's work through some examples of this. So some of the more common generalized epilepsies, we use the term idiopathic. So what does that mean? Idiopathic means we don't really know the cause for most doctors. But epilepsy doctors have used the term a little differently. We use the term to mean we don't know the cause, but it's kind of sort of genetic, and the kids are pretty much okay developmentally. But it's not really accurate, because some of these kids, like childhood absence epilepsy, can affect learning. And so that, you know, this term kind of implies we don't think there's an underlying lesion, the MRI is normal, and it sort of runs in the family. So what do I mean by that? Well, some have criticized that term and suggested maybe we should use the term unknown or genetic. But for these generalized epilepsies, that doesn't quite work, because we don't know specific gene mutations, but they tend to run in families. Like maybe Aunt June had childhood absence epilepsy, and Uncle Bob had generalized tonic-clonic seizures. So it's kind of loosely genetic, but not one specific known gene mutation. Kind of like temperament. So some examples of that would be a focal epilepsy called benign Rolandic epilepsy, otherwise known as benign epilepsy with centrotemporal spikes, which is a very common childhood epilepsy that causes nighttime only seizures. They begin focally in the Rolandic area, which is right where the face and arm motor and sensory function is. So a child would wake up maybe with arm jerking or arm numbness, and then it might spread to the whole brain, causing a focal to bilateral tonic-clonic seizure. And they might have a dozen or half a dozen seizures through their childhood, and then they grow up to have no problem whatsoever. 99.8% outgrow it. So it tends to run in families, but not always, so it's sort of genetic. As opposed to the generalized epilepsies, you just saw juvenile myoclonic epilepsy, and we'll talk about the other two. So some have criticized that term idiopathic, but I actually think it's a good term, because it means kind of sort of genetic, and there's not really a good word. If we call that genetic, that's not really accurate. If we call it unknown, it ignores the kind of genetic tendencies in those conditions. Now there are specific genetic syndromes, like Dravet syndrome. This is a tough epilepsy that begins in 6-month-olds, or sometimes a little older, but usually under 2 years. They have unilateral hemiclonic or shaking seizures, and then as they get older, they may have absence of myoclonic, and they often have febrile and afebrile or fever-provoked and non-fever-provoked seizures. MRI is normal. So this syndrome, 75% of the time, they have a specific sodium channel mutation. And so genetic testing has helped us uncover some of these more specific genetic conditions. And sometimes that can be informative. So in the case of this sodium channel mutation, sodium channel blocker drugs tend not to work as well. So it can actually have treatment implications. Now what was that Landau-Kleffner, Landau Calrissian? This is Landau Calrissian from Star Wars fame. Not Landau Calrissian syndrome, but Landau Kleffner syndrome, if that helps you remember. This is a fascinating condition that is under-recognized. And those of you who are teachers or speech therapists or nurses, I want you to know about this. So I saw a classic child with this. He was a almost 5-year-old, very smart kid, smartest in his preschool class. And he was actually starting to read. He knew all his letters. And over the course of about 2 weeks, he lost the ability to recognize letters and words. It then progressed to what we call auditory agnosia, where he wouldn't even recognize the phone ringing or his parents shouting for his attention. So basically, when you do an EEG during sleep in these kids, you see what we call electrographic status in the language areas, meaning their brain is seizing all night long in the language part of the brain, Wernicke's area. They don't have any clinical seizure. You wouldn't know it looking at them. It looks like they're asleep. And what's amazing in this condition is sometimes when you catch it early, high-dose Valium at bedtime will control these electrographic seizures. And so in this child, we treated him aggressively, his EEG normalized, and his speech came back. Now there's a lot of kids who have language difficulties tied to autism or developmental delay who don't have this. This is previously normal children, 4, 5, and 6-year-olds who lose language. So it's something that I wish there was more awareness of, so we could catch it earlier. Let's move on to more bread and butter epilepsy syndromes. So here's a child who blinks out for 2 to 10 seconds dozens of times a day. I want you to see the difference from that first seizure we watched. So he's playing a video game, you see his hands moving, and there the seizure started. He's blinking, it's like someone pushed pause. And it's done. So very bland behavioral arrest. So this would be a generalized non-motor absence seizure, and we would call this a typical absence. His EEG would show this, a classic characteristic EEG finding, 3 Hz spike wave. And so this is childhood absence epilepsy, developmentally normal kids who start blanking out, and it often affects school performance. So really the reason we treat this is to sharpen them up in school so that they have better developmental outcomes. They tend to have dozens or hundreds of seizures a day. It's loosely genetic. It's another one of those idiopathic generalized epilepsies. And it usually goes away. And only about a third of them ever have a generalized tonic-clonic seizure. Now, if the same thing starts in teenagers, we use the term juvenile absence epilepsy, and then it's a little different deal. They are more likely to have a generalized tonic-clonic seizure, 75%, and they're less likely to outgrow it. As a general rule, teenage onset, your genes kind of change when you hit puberty. And so, genes expressed in the brain, and so childhood onset idiopathic conditions you tend to outgrow, whereas juvenile onset you often don't outgrow. So that concept of idiopathic epilepsy syndromes, you have these specific syndromes, but they kind of overlap. Childhood absence epilepsy, generalized tonic-clonic epilepsy. We used to call it generalized tonic-clonic seizures on awakening, but many of these patients, it's not just on awakening, so they've changed that term to generalized tonic-clonic epilepsy. But it's a group of related conditions, and many people kind of cross the boundaries between these syndromes. Now, what about the term cryptogenic and the term symptomatic? Symptomatic means there's a lesion causing it, like a tumor or a malformation that happened in the womb, or a scar like mesial temporal sclerosis, as we'll talk about. As opposed to cryptogenic was an old term that meant we don't know the cause, but we think there might be a lesion. So we tended to use the term idiopathic if they were developmentally normal-ish, and cryptogenic if it was something like Lennox-Gastaut, where we thought, well, there's something wrong with the brain. Maybe there's a lesion the MRI is not seeing. Now that term's been done away with because it's confusing. Really, cryptogenic and idiopathic kind of mean the same thing to most doctors, so it's confusing. But so here's that Lennox-Gastaut we were talking about, which is sort of generalized. Epileptic spasms, or West syndrome, we talked about is generalized, but you can see it from a focal lesion, like somebody with tuberous sclerosis who has a tuber causing these spasms. So let me present a patient to teach you about a very common cause, the most common lesional cause in adults, called mesial temporal sclerosis. This is, I don't want you to leave this meeting with the sense that all epilepsy is devastating. Most epilepsy is not devastating, but this was one of the most heartbreaking cases I've ever been involved with. This was a 20-year-old who had a bone marrow disease, and she was on chronic narcotics for this. And because of being on chronic narcotics, she got addicted to them, and she started taking a month's worth of oxycodone over the course of a week. And so one day she ran out of her narcotics, and 3 days later she had headache, confusion, she couldn't see. She showed up in the ER, and she would be staring off, smacking her lips, like that focal to bilateral tonic-clonic seizure you saw. And then she had spread to focal to bilateral in the ER. And I came into the ER to see her, and she was in focal status epilepticus. She was, the nurses didn't recognize it, so I casually came in after an hour of this behavior. She was staring off and to the right and smacking her lips. She was in a focal seizure continually for an hour. Her MRI showed what you see from high blood pressure causing swelling in the brain, hypertensive encephalopathy. So she had so-called posterior reversible encephalopathy syndrome caused by surging blood pressure from narcotic withdrawal, which gave her this brain swelling you see in white in the back of the brain here. And then day 4 rather, her MRI now shows this memory part of the brain, the hippocampus, the area affected early in Alzheimer's, is swollen and bright. And then 5 weeks later, that area shrunk, but is still bright. And this is subtle, but take it from me, I don't know if you can see this very well. This is a flattened, bright hippocampus compared to this normal one. Now, because of this scar that long provoked seizure gave her, she developed unprovoked focal seizures that were very, very tough to control. And ultimately, she ended up passing away because of her epilepsy. So a very tragic case. Mesial temporal sclerosis. Now, sometimes mesial temporal sclerosis patients will go on to have epilepsy surgery after failing umpteen medications, most of them 6, 12 medications. And the rate of seizure freedom is 80 to 90% in these patients. So this is an epilepsy surgeon's dream, because if you take out that scar, you can cure their epilepsy. There's other focal lesions that the same stats hold true, like a blood vessel malformation here, or a low-grade tumor that you can cure with surgery. So if you take these out, you can cure epilepsy. Even in patients with normal MRIs with focal epilepsy, sometimes if you figure out the problem spot, you can take it out. And if it's in the temporal lobe, 80% seizure freedom. If it's not in the temporal lobe, as good as 50% seizure freedom in carefully selected patients. So having a normal MRI doesn't rule out epilepsy surgery. Now let me end with one of my all-time favorite patients. Actually, as I look around the room here, many of my patients' families here have children with this syndrome. So this will be a good note to end on. So I met her when she was 7. She had some very mild developmental delays. She had minimal language until about 3 years of age, and she's been about a year behind reading now as a 2nd grader. Just a lovely kid. And she began having spells as an infant that persisted when she was an older child, where she would have the slow, rocking movement of her right leg that would sometimes spread to the trunk, sometimes progress to trance-like blank staring, sometimes awareness would be preserved. They happened multiple times a day as a toddler, and they became less frequent by the time I met her. Her EEG during wakefulness showed right parietal temporal spikes for the 2 epileptologists in the room. And then when she fell asleep, became much more active with bilateral parieto-temporal spikes. I tell my patients these are like sparks. If a seizure is a fire, these are sparks. And her MRI was normal. So we put her on a very benign seizure medication called lamotrigine or Lamictal, and she was seizure-free from then until 9 years of age. She then started having tough epilepsy, failing multiple medications, failing dietary approaches, and having multiple daily seizures, so she couldn't go to school. Here's what one of these look like. The leg starts rocking. She spaces out a little bit. And again, for the epileptologists in the room, both of you, there's a rhythmic delta discharge in the mid-central head region, so a focal seizure. So her epilepsy is of unclear cause. So I found myself counseling her and counseling many children like her and kind of making up statistics about what are the odds you're going to outgrow this, based off what my mentors had taught me and my gut and my intuition. And I kind of thought, you know, puberty, genes change, maybe things will improve in puberty. And since your MRI is normal, you're probably more likely to outgrow this. But, you know, I guess maybe 70% chance you're going to outgrow this. But I realized, well, my best friend here, Bill Martin, my fishing buddy, he's got a rule. He tells me, you know what, bells are prone to exaggeration. And he's got this rule he talks about. He calls it the Bell formula for truth. He says when you take the fish size that I claim, you divide by 2 and subtract 3 for an accurate fish size. So for example, a 20-inch trout, divide by 2 is 10, subtract 3, that's a 7-inch trout. So I thought, you know what, I better dive into the literature and make sure that my assumptions are accurate here. So we talked briefly about benign epilepsy with centrotemporal spikes, or benign melandic epilepsy, whereas we're now supposed to call it epilepsy with centrotemporal spikes. They took out the benign, which I don't agree with at all. It is benign, so we should call it benign. So this is a focal epilepsy syndrome that we know the natural history of. 99.8% outgrow it. But what about all the other kids with focal epilepsies of childhood that don't fit one of these syndromic diagnoses, like benign epilepsy with centrotemporal spikes or benign occipital epilepsy, another one? This group is huge. It accounts for 1/3 of all childhood epilepsy. And most epilepsy starts in childhood. And it's gone by many different names. The literature's been confusing. I like the term focal epilepsy of childhood of unknown cause, because it indicates it's focal and MRI is normal. So most do well, but not all. Actually, when you look at these tough adult epilepsies, half to 2/3 of the adult focal epilepsies in the epilepsy surgical clinics, like OHSU, started out as this. So we can't call this benign. So here's a graph looking at when does epilepsy start. So the incident onset of epilepsy is either in children or in the elderly. The elderly usually because of stroke. So most epilepsy starts in childhood. So I think it's facetious to tell parents nothing to worry about in this condition. So let's dive into the literature. So here are 3 population-based studies. And as an overall cohort of all focal epilepsy in kids, this was about 1/3. How many of them had their epilepsy go away at some point? About 80%. How many had the epilepsy remit and no longer needed medications? About 60 to 70%. How many of them grew up to have medically unresponsive epilepsy, intractable epilepsy? About 10%. So not a negligible amount. So pearl number 1, this is not benign, even in developmentally normal children. This is not simply benign melandic epilepsy like. The other concept is, in the old literature, they called this cryptogenic partial epilepsy of childhood, as if assuming there was a lesion we couldn't see or brain dysfunction we couldn't see. And actually one of my former junior residents, Katie Nichols, did probably the best natural history study of this condition and compared it to symptomatic focal epilepsy to see if they're kind of the same. And what she found out of 360 kids, 111 of them had this focal epilepsy of childhood of unknown cause. She found the focal childhood of epilepsy of unknown cause that with very long-term follow-up. This is Olmsted County, kind of a Mayo Clinic area where they have all patients go to the same hospital in the community. So a great place to study natural history. And she found that over 80% were seizure-free with long-term follow-up. She also found that if they were developmentally delayed, like the patient I'm presenting here, that was a little worse, but not a lot worse. So that idea of cryptogenic being like symptomatic, not really true. So cognitive delayed children, 72% of them were seizure-free, so pretty good. And about 70% seizure-free and off meds, compared to only 46% of the symptomatic lesional focal epilepsies. So having an abnormal MRI does bode well. And 7% of them still had epilepsy at final follow-up, compared to 40% of the symptomatic. So cryptogenic is not simply symptomatic. And so I've got this new rule now, 80-70-10. So I tell my patients with focal epilepsy of childhood of unknown cause, 80% chance that as an adult you're not going to have epilepsy on or off meds, meaning well controlled on or off meds, 70% chance you'll be off meds and seizure free, but a 10% chance this could be tough as an adult. I'm just going to breeze through this in the interest of time. Two more factors: age of onset, 10-year-old on up, a little worse outcome. Number of seizures had nothing to do with likelihood of outgrowing. So having 50 or more seizures, they did about as well as less than 1 seizure per month. And then this was a really interesting way to look at things. This population-based study, they looked at the kids who were easy to control. In the first 2 years, they became seizure-free for 12 months or more, compared to the kids who were tough to control. They failed 2 drugs or more in the first 2 years, compared to the people in between. They hadn't tried 2 drugs or whatever. And as you might expect, the kids who were easy to control did great. The kids who were tough to control, only a third of them seizure-free, but that was a very small proportion of these epilepsies, focal epilepsies of unknown cause. Anyway, we'll end there, guys. So this is a picture of Ice Lake in the Malawas. Have any of you been there? It is straight up to get there. So the map I had said it was 6 miles. It turned out it was 9.2 miles, 3,200-foot climb. So me and the kids did this weekend, and I taught them through this experience that nothing worthwhile in life comes without some effort. And so hopefully this effort today was worth it and deepened your understanding of not only seizures, but also epilepsy. So here was the reward at the end. Ice Lake. You can see I've gone a little over time, but any questions?
You mentioned autoimmune seizures.
Autoimmune epilepsy is fascinating. One of my mentors at Mayo Clinic, Jeff Britton, is one of the world leaders in studying these antibodies like NMDA, which is so popular in the press right now. And so sometimes you'll generate an antibody against a cancer, for instance, and that antibody will cross-react against the brain and inflame the brain, like the hippocampus we talked about, and cause seizures. You know, we just scratched the surface here. There are so many causes of epilepsy. It's a very complex field, and the term epilepsy is so generic. I mean, it's not even, it's got so much stigma that in some ways I wish we talked more about syndromes than using that generic term. All right, thank you.
Thank you, Dr. Bell.